or her home offering these services. Why don't we look at this client holistically? When he appears at the facility, you are able to assess everything. That is what we want to achieve. We've had the trainings. We had the GOT as a district, which involved quite a number of our staffs from the facilities. We really engaged team. We also had the facility-based trainings with all the health center affiliates and above. Of course, with support from DELA, UPMB is Uganda Professional Medical Bureau, and UCMB is Uganda Catholic Medical Bureau. So as a district, I think we've done a lot. One of the gaps maybe that we've seen is the issue of stigma for our clients. Because now we are saying we should have like what I would call a one-stop center. When someone comes to the facility, we should be able to handle him or her at one point. Not go in art clinic, go maybe for YCC, go for. We want to look for a way of attending this client or this client at one-stop center. So the HIV issues of stigma, of course, we have been, how we have been operating on some, I don't know whether I should call it special clients, where we even deliver drugs at their homes, where we even bleed their homes, blood for viral, monitoring at their homes. So that kind of stigma is what we want to handle. Of course, the other issue has been issues of data capture, because now if you look about one-stop center, previously we've been sending people to lab, to actively for ARVs, but now we are saying we can dispense at the. So how are we going to capture data? The process will go on. Like I said, we've had trainings, we've had the health facility-based, mentorships. We invited CMEs so that you are able to discuss and see how you are going to handle this. Because you like it or not, that is the way to go. You don't want to be called unaware of what happened last time. Now, that is it about integration. HIV, next slide. Yes. Now, HIV has very many slides, but basically what I can say is that overall we have majority of our health facilities in green. However, we also need to support those facilities that are still in yellow and red. For example, we have, but the other thing I also have to mention is that there are facilities that have persistently been in red. And to my surprise, these are the original facilities. The likes of Kalibo, the likes of the Handiro, Mahango, and low volume. So we need to understand what the problem is. You are low volume, and yet you are not performing to our expectations. What is the problem? We need to help them. The data is there to actually support my statement. My other regional facilities, those other medical facilities that have been offering HIV services for quite a number of years, but still they are appearing in red. We expect them to perform so well because they have the expertise. The staffs have been working in the art clinics for quite a number of time, but still we have, according to data, we are still seeing reds and yellows. Yellow is also not okay, because yellow means yellow is not as in politics. So that is it. Of course, the other from that slide, if you literally look at that slide, there is also an issue of targets. Annual targets, quarterly targets. You find some facilities have overperformed. I don't know what do we do with our targets? Why are we overscoring? Is it an issue of data? Is it because we have an issue with our targets? So I think that is something that we need to work it out. politicians and our partners. Why do we find a facility with 250-something%? So the issue of targets, of course, the other issue is HTS. I'm trying to summarize what is on those slides. Health, HIV testing services, yielding rates. The national target, we are supposed to be at 3%. There is only one facility which in the district that is at 2%. The rest of our facilities are at 1%. What is the problem? Are we practicing targeted testing? Do we have these new innovations which are supposed to give us high yield, like assisted pattern identification, index client testing, and so on? We need to test people who have high chances of becoming HIV positive. You get what I mean? Not rather than testing everyone. When we communicate, we are testing everyone. We are testing everyone. We tested 100 and none of them is positive. So you mean, are we not screening? What is the problem? My colleagues and seniors from the health clinics, do we do screening? Do we not testing? The targeted testing? Where is the problem? Because we are meant to at least be at 3%, rather than, most of us are at 1%. 1%. Only 1% is at 2. Viral load separation. By the way, before I continue, if we are to achieve HIV epidemic, we have to perform so well on all the 395. First 95, second 95, third 95. First 95, we are talking about at least reaching and testing. Getting, at any given population, in any given population, there are always those people who are living with HIV. That one is scientific, you don't need to discuss it. In every given population, there is always a certain number of people living with HIV. So our work as health workers is to ensure that we identify them. So we want to say, in every 100 people living with HIV, we must at least get 95 people, bring them on board. Because we know when we release them, one day we will know their HIV status, and therefore we shall initiate them on what? On ARVs. And once that is done, ARVs, there is a way they prevent HIV transmission. The health workers here know it. So, if we are not achieving 95% as a district, or even when the district average is 95% or half, if we still have facilities that are in the red, those that are not reaching every 90% of their target, then there is a problem. That is first 95. Second 95, where we are doing very well, we are all in green. Those among the 95 that you got, how many did you initiate on ARVs? Not you. How many did you initiate on ARVs? If you have initiated all of them, that is 100%. If you have initiated 95, that is 95%. If you initiate 94%, that's another performance. Yes. So, linkage, we are lucky that we are doing very well. We are all green. The other thing we should do, if we are to achieve epidemic control, is the 95, the 95. Where all that we initiate on ARVs, at least 95 should have viral load suppression. As a district, I think, I don't have the update data, maybe Kasese is going to help us. I think we are still trying, we are still struggling. We may not yet be there. The last time I looked at data was a few months ago, and we were at 95, 97, but I don't know if we are still there. We shall find out. So, now, if we look at our viral suppression, like I already said, persistently there are facilities that are not doing well. And I will mention them. Actually, in the Chitrol, Mahamokaniho, Mihandiro. And moreover, these are facilities that are ongoing. Is it because maybe our operators are not picking samples? We talk about viral suppression and actually viral coverage. Is it because our operators are not fitting there? So we have a problem with transportation of blood, or our clients are not being, maybe have refused to You know? So we need to look at those things. I need to rush a bit.
Because you have extra time left, manage your time.
Okay. Now, I have made some summary on where I think we should have actions. Targeted testing. We need to develop an action on this, so that we are not simply not to be performing. We also need to look at the viral load coverage. Some facilities are simply not well. Then facilities that are not meeting their quality targets, we need to look at them. The issue of accountability for HIV commodities, the HIV test kits, and any other commodities, we need to develop an action because some facilities, I think, have issues with their records in regard to accounting for this. Of course, the other one is on integration. We need to find a way of improving and make sure that we achieve what is required of us. I think that is all that I can say. How I wish we had this presentation on our emails, and we continue referring to it. Now, I was given very many things. I'm sorry, but I have to look at them. Now,
you have 2 minutes. Be done.
Local government performance assessment. For those that have not heard from me, very soon we are going to have our internal assessment, which involves moving to the facilities. For those facilities that have received our tool, please look through it. We don't want to catch you unaware. Especially, I have to be sincere, our public facilities, center police and above. We shall be there, look at the tool, your LPDCR reports, notification forms, audit reports, maternity registers, they have to tally, we shall be there to look at that. Your work plans, the signposts in the local language, your CME books, CME reports, we shall look at them. Your valid practice licenses, we need those files, we need appraisal reports, staff establishment. We've had so many transfers, so can you please harmonize with DHO and ensure that what is in DHO is what you have in the facility. IPC facilities, you have hand washing facility, there is no water. If there is water, there is no soap. You don't have sanitation. Please can you prepare all this? VHT reports, ICCM, 097. Madam Agnes is making an analysis. She's going to start calling you and ensure that you keep copies of all the VHT reports. Then outreaches, the free outreaches, and the guideline is that at least 4 of the outreaches should be to schools. You get it, ladies and gentlemen? You are meant to have a minimum of 48 outreaches. And out of 48, 4 should be to schools. Please, when we get there, don't say I didn't tell you. So we shall read that these tally sheets mentioned in our second primary school. Mungu secondary school, 4 of them. I think for now, that's what I can say. Because of time, you are always not here. Thank you so much.
Only 5 seconds.
Yes. Good afternoon. Amos Moraki. Of the district about the compassion. Just only want to talk about one thing. We want to talk about the new test kits which are in our facilities. We are all aware that there's a new test kit which health centers means hospitals and health centers, those are both. Mostly those in public facilities, the PNFPs are not yet got that testing. So currently the information we have is that less data. That's the current information we have. So we add data, you can replace it and record that new test kit in the place of data. Please, that new test kit is under the Buy Uganda, Build Uganda policy, which the president is trying to spearhead. That test kit is being manufactured in Uganda. And there are other test kits which are going to come on board. You are going to see a new test kit with the same company. That is for malaria. You are also going to see that on sickle cell. It's also going to come on board. You are also going to see another duo. You are not going to see the old one which is Abbott, but you will also see that one which is still of Buy Uganda, Build Uganda. So I urge you that please let's embrace the new test kit. For those people who are not reached, who are going to come there, and we teach you how that new test kit works. Thank you.
Thank you so much for the update, and we will proceed as follows. Colleagues, allow me to. We are going to have a presentation from Warehouse Hospital. I hope it is already loaded. Following that, we shall have national medical stores, and then we'll go into partner briefs. I will request that as partners come on, we request you to really give us just the briefs, because tomorrow we'll have a full engagement with you the whole day. Today we don't expect you to have presentation plus briefs. Tomorrow we shall get further. Let us have Warehouse Hospital. We shall go by NMS and we get the briefs as we go into near the closing session.
Hospital by the senior psychiatric clinic officer. In fact, this is a privilege, because like mental health almost is a neglected area. But I thank the district administration, our DHO, and our medical superintendent, because they have done a lot. They have recruited staffs in mental health. Currently, we have senior psychiatric clinic officers, assistant nursing officers. What is remaining is how do we distribute these people so that we are able to do what? We are able to produce results. And go to the next. Next. We are in general hospital. We have been at this condition. Basically, among the conditions that is a burden to our facility, we have a bipolar affective disorder, where we call it a mood swing, which is having around 30, we saw around 31 patients in the month of April to June. Epilepsy comes the second.
That's 1 quarter?
Yes, 1 quarter. So this shows that we are having a big increase in the number of psychiatric cases, because everybody needs what? Needs the service of mental health. We have been looking at the secondary school, where we are having an increase in the drug abuse, and which is a big challenge. In most cases, this thing, if we are not careful, we may not have our youth who will be productive. Because most of these youth are indulging in what? In drug habits. And we are not taking care both at school and at home. We have the other one, conversional disorder, where they use it to say a dancing syndrome. They use it to call it hysteria. This is mostly affecting ladies. You'll find in a secondary school, they are saying they have a macolongo. And you ask yourself, among the boys and the girls, it's only the girls that who are affected. And in most cases, people have been going to which doctor that they are looking for what, but they are looking for it. This is just a psychological thinking turning into a physical problem. Like if a child was saying that, basically, I'm going to fail the exam, what you will do, you will have what we call avoidance syndrome. The mind prepares you so that you are able to avoid things which will bring conflict in your mind. We call it we can call it a mental defense mechanism. So at the end of the day, you may have paralysis of the arm, so that this person is not able to do what? To write. Or you may have poor vision, so that this person is not able to see, because he wants to do what? To avoid. So, as warehouse people, we have seen challenges, especially with our religious leaders. In most cases, they refer these cases. When it is too late, they will first say, we are going for prayers. They are praying, no improvement. At the end of it, they bring the patient to what? And we have been having such a story. That's why we are having all these numbers. Inpatient. Our inpatient, we are faced with the challenge of we are mixing these patients with the general patients. Because like we don't have a separate one, a separate psychiatric unit. Whereby cases which we may find, but basically they would need maybe a specific place. Because you find that if someone is aggressive, there's a possibility that this person can even remove a drink from some other patient who is not mentally sick. So it becomes a challenge in the management. And secondly, we health workers, our mind is just focused on saying either I'm diagnosing malaria. Like if you have a case of somebody is having the hypokalemia. We know hypokalemia can cause what? A confusion. Recently we had a patient, this person had developed mental confusion. And what they were thinking, they were saying maybe we refer to a psychiatric officer. But when we reached there, we said, let us do the investigations. We did the extended electrolytes, where we found out that potassium was completely low, and which was causing the confusion. The same applies to diabetes. When there is high blood sugar or low blood sugar can bring what? A confusion. So, when health workers work as robots, like you don't think beyond, you think everybody who presents with confusion, it is mental health, then there you are losing track. Because we have seen most of these cases, they will present as psychiatric conditions when actually the problem is medical condition. For instance, even for HIV, when the viral load is high, we expect this person to develop confusion, what they call HIV psychosis. So, in most cases, mental health cuts across.
Don't explain your client too much with the burden of mental issues, because you have very little time. You need to talk.
Okay, I talked about this one, like we are having the high level rates in psychiatric cases, the challenges which we are having, challenge in managing epilepsy, especially people who fail to do what? To adhere to treatment. In most cases, people who have been presented with epilepsy, most of these patients are isolated. When they are isolated, they think epilepsy cannot be treated. Epilepsy can be treated depending on the cause. Because like if somebody is having high blood sugar, it can lead to what? To seizures. What we call epilepsy. So if you find out the cause, you will be able to manage. But if you don't know what you are managing, then you won't treat the person effectively. And go to the recommendations. The recommendation. We feel they should increase the resources for mental health. I think this is the beginning of it all. Because we have not been gone, and for me, I'm happy if we can be given a platform. This shows that possibly there is something big coming. Must take collaboration. We feel we should work with other partners because mental health is not an isolated part. It touches our daily life. So if we think that not possible, because like in our facility, we always move in all departments, both the medical ward, the surgical ward, pediatric ward, maternity ward, meaning mental health affects every department. Even some of us here, we may be having issues, but we don't know. Another thing which we think maybe possible they will help us is we have facilities which are having psychiatric nurses, but basically maybe they are using them for they have allocated them other duties. We feel we need to identify these people so that we empower them and we see how we can move on. Because basically it's where a hospital that basically is somehow providing most of the handle these mental health issues. They handle cases from Congo, they handle cases from Kasese, we are even handling cases from football. So meaning we are cutting across the whole region. So meaning if we empower these health centers, especially the central force, which have psychiatric nurses, we are able to do better. Then maybe another thing, if maybe the district would think, would we have a mental health department that basically will deal with these psychosocial issues, or a ward, so that we have a ward for these mentally sick, because the cases are on increase. Then we will think, can we be able to do most of the community work or school health program? Actually, like we attend to these teachers, because in most cases, these teachers are not able to identify children who are mentally sick. They will continue beating them, thinking these children are stubborn, and yet these children have a psychiatric problem. So we feel if we can improve on our school health, basically these teachers can be able to provide psychological first aid. Instead of beating these children or students, they are able to guide them and take them to the responsible officer. The last one, I felt possibly the radio talk shows, and if we also provide means of transport so that these people can do some kind of home visiting, like a motorcycle which can navigate in these small areas, so that we are able to reach our clients. Thank you so much.
Thank you. Thank you for the presentation, and I think people, you are taking note of whatever concerns. We need to receive the next presentation. After that, we can have a few responses before we go into partner briefs. So let me assure you are taking whatever you need to ask about, rather the presentation. We are waiting for the next presentation. That is National Medical Stores. Let us receive their presentation.
I'm sorry, I'm playing practice prevention.
You're right.
This is the health meeting, so I think the meeting is good evening, ladies and gentlemen. My name is Elubert. I work with medical students, and I have to represent this region at the national level. There are just three things that I'm going to touch.
There are just three things that we are going to touch as far as national medical stores is concerned. That is plan, the way we plan, our orders, and what we deliver. But before that, I will put in a brief introduction. Enacted by the Act of Parliament 1993. We are mandated to do only three things, that is procuring, storage, and distribution of essential medicines and health supplies to all government-aided facilities. And we don't do that in isolation. We do it in collaboration with Ministry of Finance, Ministry of Health, local government, and our club IPs, implementing partners. And I want to put this clear. In NMS, we have two categories of stocks. We have ready-to-buy stock, the stock that we procure using our access. Then we have program stocks that is supported our partners. So it is the responsibility of national networks to store those items and distribute them on behalf of government of Uganda and our partners. Procurement. Actually, in Kasese, that's our inventory, we have 88 facilities that we interact with from time to time. Distribution is there. We have one general hospital, 2 health centers, 4, and 27 health centers, 3, plus 58 health centers, 2. Procurement planning, we do procurement plan every financial year. We plan with our facilities. And this is when we get documents that help national medical to perform its duties. To perform its duties. In level 4 and above, we get procurement plans. Level 2 and 3, we get what we call a basic kit. These procurement plans can be adjusted depending on what quantities have reached. Members can sit and fine-tune those plans to meet the needs of the facility or the district, the current needs of the district. But during our procurement plans, we have challenges also in them.
One of them is the limited budget. Bear with me, the health centers who are here. We have to bring the items to fit into the budget. So, our members who are here, kindly please advocate for increasing the budget for essential medicines, so that we have enough medicines in our facilities. The other thing is, dwindling budget also affects our people. You find the intern will look at how can I go and staff in the district. The whole day will not give them. So we basically, so when these activities come, please support us. At least we keep. Or better sleep with land. Then other things will handle. The other thing, mix of health and also mix of finance, all districts asking us to support supply chain activities. We are not saying that they are not supporting us, they are supporting us, but we are still asking more support from that. Ordering is one of the activities that we enforce. Our ordering has been improving from as low as 69% to 89% orders that are accurate. But that is not enough, because there are other facilities, other districts that are already at 100 for ordering. We still have challenges in ordering as facilities around. One, we don't have equipment in our facilities to place these orders. Our health centers walk the right distances to have the order placed. Even the internet connection in our facilities is also a challenge. Our health centers are using their own monies in a cafe to place the orders, and that has affected the quality of our orders. So you find the quality of our orders is still below 61%. At least to move from 40% to 61%. So there is a need for us to allocate resources so that we have our facilities not facing those challenges. There is also knowledge gap. Some of our people fear computer, yet the system has evolved from paperwork to computer. Many facilities that are visited during this type of ordering, they tell you, we have already done a hard copy, and we have given it to so and so, to take to so and so. So that compromises the integrity of the orders that we receive. That is our budget performance. This district received 3,262,997 shillings per annum for all facilities for essential medicines. And national efforts has delivered 3,009 million shillings. We have that as a balance carried forward, giving us a percentage of 92% on budget performance. I expected it up, but it takes a long time. Now, the balance which is remaining, our health center force and technical hospitals have already placed supplementary orders to clear these balances. Level 2s and level 3s will clear the balances as we go through this financial year. This financial year, we are going to have 2 delivery schedules. The previous year, we had 3. And our adherence to the delivery schedule was at 90%, which was good enough. That's why you see our facilities now have medicines. And some of them are wondering where we could go ahead, because the deliveries were regular. I think here you can bear me witness on that. We also do what we call stakeholder engagement. We engage with local governments that we have. We engage with your unique meetings in committees in the health facilities. We engage with LOC ones whenever we find them. And on top of that, our board of directors of National Network Trust also steps out to engage with local government with the effort to improve service delivery. And on that note, on 8th September, we'll be having board of directors here in Kasese, engaging with CAU, DHO, DSO, and any other interested party that can be available. Probably finally, we have what we call in-view. In-view is an innovation by National Network Trust to capture our milestones. Our images that we are seeing here with the DHO took a lot of work, but nobody captures that work. So this magazine is going to capture all activities that our health workers are doing, activities that we are doing as government to improve service delivery. We also do what we call capacity building during stakeholder engagement. And National Network Trust was able to handle higher level facilities exhaustively at 100% level through what we call medicine therapeutic committees. These committees have been established in health across and general hospitals. That's why we find that there is a great improvement in the plans that we receive. With support from NDA, Ministry of Health, to strengthen MDCs in our facilities. I want to say that I just have like 3 recommendations to put forward. One, technology. The country is moving from analog to technology. So when the district is planning, they should plan on advanced technology. Train our health workers so that we improve on our efficiency, mostly on data capturing and data use that can be used for making informed decisions. Preventive health care. Budgets will never be enough. But when you are going to preventive health care, we'll go a long way. It has so many activities, so many benefits. One of them is improved productivity, because most of our people will be healthy, so productivity will go up. We also need to capture accurate data so that we are able to allocate our resources in a better way than what we have. At least you can sit and look which facility receives work. I have taken note, there are facilities that have been elevated to level 3, but their performance is still in level 1. 2, you only make items in London. So this should look into that so that upgrade facilities that really need to be upgraded. When we do that, we'll allocate our resources well. For God and my country, I serve you.
But you need to join the team so we can ask questions. 5 minutes in the last session. If there are any reactions to the presenters, right from the HM presenter, someone spoke about integration and performance review from government to another. Then director and NMS. 5 minutes, we go to the last session. Some people behind the audience, they are behind you and within the chair. Yes. Brief to the precise and brief to the point.
Mine is just a request. Thank you.
from my friend of HIV. It is possible that we also help our older people to be tested. Because in most cases, they say we are old. You can be there, okay. And my friends from where I wish he had there a good time. The way I was talked there, thank you. He has talked about school. This is the mental health. And people are committing suicide because of that. So, on your way of doing things, people can train for people to help them with their tasks. I think that's very, very important. So that we help the generation, because people are training themselves. Then lastly, I think, what's the last person? No, Stowers. Okay. Stowers are saying now that we have been a person from medical Stowers. Sir, I don't know whether it is possible when you are supplying also to include the drugs for non-communicable diseases, especially our older people suffering there. Hypertension, whatever you want to be here, stock out. I'm appealing to you people who are health professionals. Please, when you are making the order, include those order. Then if they are not coming, then we shall go to him, because he has given us that they are planning. I think that's the thing I'm not trying to do that. Thank you very much. Thank you.
Thank you, Elder.
Yes. Mine is for the psychiatric officer and then the NMS. My focal person for that and the procedure I chair has been telling me that we have never changed the code. The NS Center for the General Hospital. I have now proved it. Because that, as per your data, you have only the general hospital, only one general hospital, and I want to believe that is well. And you have been getting that problem. So please, I have seen it myself, change it. We are now a general hospital. Therefore, we have changed already flag. Number two, the psychiatric ban. DHO, if you remember, you are the chair. The session that was interesting in football was the mental health. That's when I learned that we are not supposed to you people who for man. They have mental illness. He has talked about the church issue. Church is referring, praying for them. But other than that, because he was here, unfortunately, he left me in his shoes. They go beyond that. Do you know that even in the church, I am a Catholic by background. I always ask them when we pray and they say, see, and something that cannot right. You are competing with your praying. Talk about what you don't know, what you don't understand. And these people, not only that, the Pentecostals that are here, you find people praying, these people that are aware of that. We pray, all of us here will have prayed. So I want to think church should be involved. The psychiatric officer is telling us the truth. The person who was telling us for was a very serious doctor.
Yes,
and I summarize. But you also understand that we go into the church and they made the way to worship. They always pray that they always pray very clear with the ones that are very orderly. So when you say,
Thank you, Chair. And for some here, on mental health, the mixture of psychiatric patients with general patients in general hospital. Town clerk is here, please. Let us look around and see what we can do. Because mixing psychiatric patients and general patients can be very dangerous. We need to look around and see. Let us plan something. Staffing, I know we are recruiting. Even next week, you might give 4 more psychiatric staff. So that will be done. But town clerk and the facility, let us plan and see how we can deal with this problem of mixing the general patient and the psychiatric patients. I think we need to almost close in here unless they fear the patients. As partners, please prepare to come and give us briefs. As requested, we shall have details tomorrow. Thank you.
Yes, about positivity rate of HIV testing, there is need to consider the fact that in private facilities, we test by request and money. Sometimes you will screen, the person needs to be tested, they don't have the money to pay for the test. You advise them to go to a government facility, sometimes they won't go. Two, someone wants to test for HIV. When did you last test? Last month. What were the results? Negative. Why do you want to test? I want to know. Pays money, you test. You just a private facility. It's difficult. So that can affect the positivity rate. We may need to put that under consideration. Two, integration. Integration with HIV management, in my opinion, is simple, but it requires manpower. Whatever Baylor and other partners have been funding is what health workers are supposed to do, by the way, not only for HIV. Whatever they've been doing is what every patient needs. But because they have concentrated on HIV, it seems as if it is for only HIV. Finally, so manpower. The moment there is manpower and supervision, that's okay. Finally, this is a request about basically integration. In a long time, in the recent past, I've noticed that government facilities, government is improving healthcare services in the government or public sector. I request that as this happens, I have seen dramatic withdrawal of government-funded health workers from facilities, especially in the recent past. That means private facilities could be getting deprived in some way. Let there be a transition plan. I don't know if it is, but there is a possibility it isn't, by district health office, to ensure that as we strengthen government services, private sector is brought on board. Finally, in this perspective of private business in health, where we also contribute to the table, performance and health service provision. I ask the district health office to find out and engage private systems in how they operate, not only in health service delivery by health workers, but also management in terms of motivation of health workers. For example, are health workers in private systems being paid? Who stands in for them to be sure these people are being paid? If they are not being facilitated, how do you expect them to serve? Yet actually, desperate as they are, they need to give somewhere. The district may need to engage and pay a lot of interest into matters that affect performance in private sector. They would be one of the reasons we have rates. We may need to investigate and find out, do they have officials in charge of data? How do they handle their data? So I think district should also concentrate on that. Thank you.
Thank you. Thank you for those reactions, and I think we take a note of what I say. As we go into the last sessions, remember, we shall be having, for all this that we have been doing, we will please the rest of the facilitators and other taking the questions. After these presentations, the updates by partners, we need to make the last session of recognizing performance. When we come here, we need to see who has done what and really recognize people accordingly. So we are going to invite our partners in some order, up front and past briefs. As I requested, please just briefs, because tomorrow we have the whole day of partners coordination which are engaged. You can have all your own presentations, but for now, just past briefs, and I hereby welcome a representative from NFL, Gamma Front and Plus. Any briefs, I'm really ready to digest anything we have tomorrow in the department meeting. Thank you, you're welcome.
Yes, good evening, everyone. All protocol staff. I'm Paul Eric. I work for Benavo. I'm based in Port Portal as the intervention officer. We are three in the region who coordinates the health program. Our team lead is called Eunice Sule. I know most of you know her. We have a colleague who coordinates EMS. Emergency services, then may coordinate the maternal and the newborn. I think I don't have much. Our focus is we need to reduce maternal, preventable maternal, perinatal, or newborn deaths. That's why we are trying to put emphasis on strategies towards avoiding the three delays of the delay in the community, delay in the reaching facility, and delay in receiving care when the mothers are in the facility. We also have a partner that we're working with, Obama, they're also here. They're joining hands for us so that reduce preventable maternal and newborn deaths. We have critical interventions that we're working on currently. One, Jason talked about the Kamuli model of consolidating some resources within the district to support referral system. Because most of our mothers who have seen health workers complaining that they reach facility late. Reaching facility late is one of the reasons that have been emphasizing. So we want to talk about on the proper quantification. We have started an intervention to supplement what NMS is doing in strengthening the aspect of correct quantification during planning and putting more emphasis on the vital commodities compared to other commodities that patients can easily get. We have seen incidents where we have a lot of stock of protein, but magnesium sulfate is lacking and the mother will die because of that. Yet protein and Panadol, the patient can easily get the next street. So we are trying to advocate to health centers close and the hospitals because we are a single facility. Let's focus on the vital commodities that will save life of the mother and the newborn so that we don't lose life. And lastly, on the establishment of quality care, that's one area we're focusing on, and we'll be strengthening more on the aspect of QI and IPC that my brother Julius presented. And we're calling upon commitment from leaders. Our principals will be Chairman Board now, we used to be Chairman Cubic, now he's Chairman Board of Rocky. Leadership is critical, even at the health facilities. The reason why you in charge are here is because without you, that facility can perform poorly or can perform to the best. All depends on your leadership and how you're engaging your staff, whether they're many or they are few. It is your leadership skill that will make the facility shine or the facility perform badly. Our focus is on aspect of leadership, and I think in the course of the year or early next year, we'll be building capacity of all the leaders once again in a critical
happening between 5 to 7 now. Those who need to move, we shall take further tomorrow. Then another place come up front and we can take your
Nicholas Nkili is my name. I work with Bela Uganda, and I oversee the hospitals as a cluster head. Bela Uganda, we support HIV programs and global health security. Through global health security, they have one other presented. We support active notification of diseases. So far we have 3 global entries. One being the World Wide Global entry. Here we do screening for all migrants coming within the country to ensure that they don't have any notifiable disease as per the World Health Organization guidelines. We also have multiple at the landing sites, one in Kayanzi and another one in Kapwe. So all these we have dedicated staffs who do screening, and in the case of any notifiable disease suspect, active notification to the district is being done to ensure that the people of Kasese and Uganda at large remain safe. We also support HIV programs. Here we do technical assistance to all government supported facilities. And currently we are supporting 30 sites, government supported facilities to ensure that they provide quality HIV care services. They have senior nursing represented. We have also been at the forefront that we support the rollout of integration for all government supported facilities. And I also want to use this opportunity to thank the DHO and his entire team for working hand in hand with us to ensure that at least we support, we train all facilities so that they do away with fragmented services and take care of clients using a holistic approach. In HIV support, we do a lot of work. We do capacity building for healthcare providers. We have some human resource for health that are supporting all the 31 facilities, a wide number of areas, including lab, data management, and triaging, most of these facilities. We also have, we also do stock redistribution and management together with the district stores to ensure that at least all facilities have adequate stocks so that we don't have misopportunities of where people are going to miss out on their medication because the facility has missed out or the facility has not been having supplements. We also do data management together with the district. However, before I leave, one at DHO and the entire team, I want us to think about these few things. That we need to work hand in hand to ensure that the people of Kasese are safe in terms of HIV. One, a lot of the landing sites we have observed that we have post-generational sex. Kasese is blessed with around 6 landing sites, and what we have totally observed is there is a lot of post-generational sex. And we believe we need to work hand in hand with all different partners, key stakeholders within the district to ensure that at least we work towards ending post-generational sex within our landing sites. Then when you go to the landing sites of Kahembero, we have a church. That is called the end time messaging. These ones are like one presenter here saying they are advocating for people to go through the word of God free from HIV, which we believe that this is not the right thing. People need to seek on taking their ARVs. That's what we can have. So it's not a role for only us, but whoever is that to do this duty, we believe that you have something that you can do to ensure that you bridge the misconceptions that are happening within the communities. Then still on the landing sites, they have a belief that for them they believe in the 3 W's, women, water, and wine. So when we talk about taking and any other prevention service, they feel it's not necessarily important to them. So we believe that together with the DHE, we really need to work hand in hand to ensure that we build the capacity, we create awareness so that these fisher folks really take up these services. Still in Kasese, we are blessed that we have a border, we also have Hima Cement Factory. That means we have very many truck drivers. As an idea, we have come up with the safe spaces where these truck drivers can come and access free services, free HIV services, which we believe that the district can also come and support and integrate the HIV services in these safe spaces with the other services, so that the truck drivers that usually move at night or over the weekends can easily access HIV services and other services from within these safe spaces. Currently, we have one in Hima, another one here near Manyasa, and last one in Imbonwe. When I go back to what Mr. Kasese presented here, I think we all observed that where we are being bad was the NCD spring. NCD here, we are looking at the non-communicable diseases, including hypertension, diabetes, mental health, and these are the major killing diseases within this country and Kasese at large. But from what we saw here, some of our facilities are still at 0%, and we have the interviews here. So I think interviews we need to really have a keen eye on that data, and you see how best we can work together to support the communities that we serve. Thank you so much.
Thank you. And I'm going to come up front, Frank, please come up front and give us a few briefs. Just brief. Details tomorrow. I've quite a number of around 11. Be quick, precise, the point.
However, I work with Vision Spring, and Vision Spring is global. Vision Spring is a global social enterprise that aims at ensuring that reading glasses are accessible. To millions of people across the globe. So how we do it? Through conducting free eye screenings, and however, for specifically Kasese district, we are implementing a Clear Vision Collective initiative, which is an initiative by MOH, Ministry of Health, and it is through the local government structures, and we are doing this in collaboration with different partners to ensure that eye care services are accessible by local community members within the district. So some of the partners that we are working with, one is BRAC, and BRAC's responsibility is to ensure that free eye screenings are conducted in our community. I am hoping you have seen this ongoing at the health facility and within our communities. And for those people that are screened and they are identified with presbyopia, they are given free reading glasses. and to others that are identified referred to Dr. Arunga Eye Hospital. So Dr. Arunga Eye Hospital becomes the other partner that we are working with to ensure that those that are identified with cataracts receive surgery and regain their eyesight. And Dr. Arunga will also be implementing a school eye health initiative within 40 identified schools within our community. The other partner that we are working with is CHI, Clinton Health Access Initiative, and this organization is mainly working in collaboration with Ministry of Health to ensure that reading glasses are integrated into the government's mainstream supply chain, and once we are successful, we shall be able to have reading glasses in our different local government health facilities. Yeah, so for more updates, we shall get to hear those tomorrow in the partner performance review meeting. Thank you.
Giving advice, I said, overboard, they are talking a lot to us, talking a lot more. But I'm going to appreciate them for coming. And when you mentioned, I don't like it, I thought you are going to have them on board. Someone said when you come here, then you have also talked to them, but I think you should also invite them to come and speak. And please, just breathe. We are not talking a lot. We are saying tomorrow we are going to do the whole day and we are discussing all the days. Here, just the people.
All right, thank you very much. Good evening, ladies and gentlemen, all protocol staff. I'm Dr. Arunga, the Executive Director of Arunga's Eye Hospital, and we are based in Port Portal. For the services that we offer, we do a full range of optical services, ranging from reading readers to prescription glasses for anyone who has a refractive error issue. Number two, we do use modern technology to do investigations. So in that case, we do eye scans. For many people, it's news that they're actually eye scans. This is feedback that we have received from our beneficiaries who have come to seek care from us. We also do all types of surgeries, and when it comes to cataract, we have the manual method, which most people are familiar with, the small incision, but then with the advancement in technology, at Dr. Arunga's Eye Hospital, we also do computerized eye surgeries, where there is no cutting, there is no pain, and your vision is restored at just within 10 minutes. That is what technology is doing when it comes to embracing technology. It is still used, so anyone who is afraid of surgery of the eye, do not delay to think that everything is for cutting, not anymore. We have also advanced in treatment that we also do cornea transplants. So anyone who needs a cornea transplant, we also do that. We import tissue because we don't have tissue banks in Uganda, but at the end of the day, someone's vision is restored from being blind to finally getting their vision back. Isn't good and amazing? We also do community screenings. You must have had us. I know you're talking where Kagando. We have been there, and still we use technology when we are doing our outreaches because we know the importance of data for us. When we have been working with the facilities, one of the things that I would like to bring to your attention is that the significance that teams put to data is low, and which is very evident in today's presentations. So teams need to really embrace data, because when you have seen all the patients and they are gone, the only thing that you're left of that patient is their data. So if you cannot appreciate it by the way of you collecting it, to see that it's quality data, it's complete, and you submit it in time, then most of your work is not going to be recognized because you will not have any evidence of it. We also are currently going to be rolling out the past school program, as our Victorian has mentioned, and we're going to start from 40 secondary schools. Why secondary? Because that's where significant refractive errors are. From the biostats presentation, I picked key issues that are affecting eye health. One is that there is a lot of allergic conjunctivitis. that is among the top 10 leading OPD attendances. Here, sure, this is what we have experienced at our hospital in Port Porto. We are receiving a lot of people from Kasese. Yes, we are serving the entire of the Rwenzori, but when it comes to Kasese, the rate of glaucomas, you cannot tell. And now I can see where it's stemming from, because we have been looking for the root cause. Why is there a lot of glaucoma in the community from Kasese? It's because with the allergic conjunctivitis, most of the drugs that NMS is supplying are steroids. Chronic use of steroids will predispose someone to glaucoma. And most of the people who are coming with glaucoma, they are young and it's end stage. And unfortunately, it's irreversible. It causes irreversible blindness. So when it comes to your health education sessions, please tell people to stop self-medicating with eye medications, but also the clinicians here, that's what they know how to do. Keep what is available and their steroids. So they are really also contributing to the high burden of irreversible blindness that we're experiencing at our hospital. And how are we going to overcome this? It's early screening, which is a preventive way. So when we come to your facilities and request you to work with us, please know that it is for your good. And as for the general clinical officers, there is a package called primary eye care. It is a tool developed by World Health Organization that can help them to build their own personal capacity so that they are able to manage these eye conditions better. And what they cannot manage, they refer. It's as simple as that. As I close, integration is very important. We have seen diabetes, we have seen hypertension. They are key at neuropathy, which is sole cause also of irreversible blindness. So make sure anyone who is diagnosed with high blood pressure, anyone who is diagnosed with high blood sugars, also get their eyes checked for retinopathy. In conclusion, I have heard most of the presenters and most of the issues that the in-charges and the leaders are grappling with are issues of change. This is the challenge I'm going to leave us, ladies and gentlemen. Whereas this expects you to change, you expect that this to change, everyone expects every other person to change. This is the challenge. The change that you want to see begins with you. Take it upon yourself to first change yourself, and then you can work on changing others. Thank you.
Very self-medication and so many things. I want to invite someone who, when I was presenting, spoke about the farmer. And the farmer is present, please come up and followed by Rafa, and we proceed to that. Very quickly, farmer is present, and we introduce on time. We have a little present and award best performance. Farmer, can I say how many minutes?
Thank you very much, Mr. DHO. Protocol staff, ladies and brothers, alive, an MNH organization supporting Kasese and our through giving free transport to mothers who are going to give birth at health facilities. We thank the district, we thank the stakeholders, the midwives that we work with influencing this. We have seen a lot of change. We are still there, like Dr. said, we have a lot to discuss tomorrow. The challenges we are facing in the field, but there is great work. And as a way of sustainability, because we know projects come, projects go, we have an aspect of saving for health in our communities. In Kasese, we are in 6 sub-counties in only saving for health, but transportation is within 10 sub-counties. When I talk of sub-counties, I mean I combine both of them, around 4 town councils and 6 sub-counties. But saving for health is in 6 sub-counties as a way of sustainability. We are giving transport, we don't give any other thing. they ask for a glove, we don't give gloves because we don't have them. So these people should be ready, save for health instead of, in addition to saving for rice, for clothes, for Christmas, they save for health. And I want to bring to your attention that there is a lot of great work that is being done in these saving groups. We have around 106 saving groups in Kasese, and they have saved so far in 8 months a tune of around over 76 million, and this is their money. And it is only used, it's only accessible when you are going to handle a health issue. Is it transport of the facility? Is it a medical bill? Is it you went to a facility and they do not have some, they recommended some drugs, but you need to buy them from a pharmacy or clinic. So this is where this money is used. We work in 18 health facilities, 4 PNFPs, I think, 3. That is St. Paul, St. Mary's, and Yaugando. Why St. Paul and St. Mary's? Because whenever we can find mothers, some of them would prefer to come to those facilities, and who are we to stop them? Therefore, we included St. Mary and St. Paul to them, and through the M&E department that we included in Yaugando, the PNFP, Health Center 3, because of its core value in the community where it is. We want to call upon everybody, because we have a lot of challenges, insecurities of our transporters, at night, the roads, a lot of stuff. So together, Bama can work on roads, DH office can work on roads. It needs combined efforts. A lot will be spoken tomorrow in our presentation, and we believe this is for the better of MNA services in Kasese. Thank you very much.
Thank you. The next one comes up front. It's time 2 minutes. We don't wrap up to talk of anyone. Yes, please, 2 minutes.
Thank you. Every time I try to speak in conduct, it disappears as soon as I start. I don't know who is running after me. Good evening, ladies and gentlemen. My name is Aliat Kashuba. I work for Resource Center for Research and Advocacy. I work as a project manager. On that project, we are aiming at accelerating access to English family planning and serve communities in Kasese. We are working within 11 sub-counties in Kasese and one in Munyangabo, that is Pahunian. We have employed different initiatives that aim at accelerating family planning, access family planning rather. I got disappointed when I was following up the presentation from ADFO about family planning. We are aiming at reducing teenage pregnancy. I got disappointed the whole day. I've been asking myself several questions. We have less intake when it comes to family planning, and we have reduced teenage pregnancy. Should we assume adolescents are abstaining? Question marks. Should we assume our data is not tracked enough? There are many questions. I know we shall come to resolution. Then another thing I want to talk about, of course, I will explain more about the project tomorrow since we have enough time. We have been talking about engaging the religious leaders, and there is one key group that we have left out, and this includes the traditional birth attendants. In one of the dialogues I heard in Pausanda, I happened to talk to one of the traditional birth attendants, and this lady, I was aiming at eliminating them. She stood and asked me a question. In case we get any emergency in the middle of the night, and there are no transport means to the facility, what do we do? In case we are the one to handle the case. So, as partners, this is up to us to make sure we collaborate with them, how to include them, to train them to be the gap between the traditional birth attendants and the facilities. We can't do without them. We need them. Where we are not, they are taking part. Allow me to stop here, and I wish you best for the evening. Many thanks.
Thank you, thank you. We need to have a few more like Richard still here? Richard still here? Can we have Richard, please? Try to reduce to 1 minute, followed by PSI. PSI is having to speak up. Please do after her. And finally, we shall have someone called. Yeah. So, Richard, PSI. Yes, I'm not to see what is going on. After that, we shall start next.
Both Kasese the Emily Richard Uganda is a youth-centered organization that basically deals with empowering young people with accurate SHR information and skills. Our major areas of focus is HIV awareness, livelihood, and SRH. So in Kasese, basically, I'm going to focus on the main project, UDecide, that we have been implementing for the last 3 years. UDecide is a project that its major goal is to reduce the maternal mortality and morbidity rate. This is through giving FP services, and our target between 12 to 24 for the young people and 25 plus. Some of the activities that we have employed so that we are able to reach out to people. We have done community dialogues in the different communities where we engage local leaders, community people, religious leaders, so that we sit and discuss around ideas, develop ideas on how to make better informed decisions, especially on family planning. We also have what we call the health outreaches, where we do them at the healthy facilities that we support. In Kasese, we are supporting 15 healthy centers and 5 healthy centers on permanent methods. So during the health outreaches, our target goal is 25 plus age limit, where we give out health education and we also give them FP services. We also have what we call youth days. Basically here we are targeting young people from 12 to 24, and these are spearheaded by our peer educators that are trained, whereby they reach out to these young people, they give them healthy goals, and they end up taking any preferred method of FP. I'll also talk about the main dialogues. We have had a challenge of men resisting to be involved in FP. So we have tried to employ another system of basically main dialogues, whereby we reach out to them to where they are. There are some places that we have visited, especially those places where they take, I don't know how that local beer is called, but yes, because we realize that inviting them to come for dialogues, they actually don't come, a few come. So now we reach out to them, we find them where they are, where they're having their mainly discussions, and we engage with them. And of course that changes a lot. It has helped us to also build on the numbers of vasectomies that we have gotten. We have also done healthy facility incentives, whereby an amount of money is accumulated from the performance of the PhDs and the peer educators attached to a certain facility that we are supporting. So this year, over 6 facilities. Over 6 facilities are going to be awarded, and they're accumulating to around 55,600,000 plus. So with these incentives, we reach out to the facilities, inform them that you have accumulated maybe an amount of money of 10 million, and what equipment would you think will be beneficial to the facility, because we are aware of the maternal rates that are rising, but we are trying to control them. So through that, we are able to give them the materials and the equipment that they need. I think most of it all will be discussed tomorrow. Thank you so much.
Thank you. A big clap to the requesting that PSI is the last one, and then we can go into the last closing session. The teams can prepare to come up from PSI, please. And of course, requesting that our partner, that our staff who are outside should come in as we go into the closing sessions shortly. PSI, please remain at tomorrow meetings.
Thank you, Adietro. Good evening. Yes, I think along the discussion in the morning, I did submit part of my highlights. With PSI, Public Service International, we are working now to in 51 districts, including Kasese, and one of our main projects is called this project. This is delivering innovations, self-care, and along that we are supporting family planning services, but also saying that mothers are able to access family planning services through what they call self-education. In Kasese, we are supporting 81 facilities as now. Our target is now 100% coverage of all public facilities. And I think the vice can check where we are lying in terms of supporting public facilities. So in our work, we work through existing strengthening blocks. That is capacity building. In these 81 facilities, we have trained additional providers, but also continuous support, supervision, and mentorship. Through what we call the mentorship model, where trained providers are actually going to support facilities with gaps. But also we work with the PhDs with the different activities around reporting qualities and also continuous support facilities. And with this, I think in tomorrow's discussion we'll be able to share more. But what I want also to add on my about the family planning update, which is really we see is dropping, and yet we have resources within the district through partners. And I will encourage the facility that is majorly, because we see some of this gap is about leadership. For us as partners, we can be supporting through facilities, but there are issues that we need the facility that is to come through. So I will request initiatives to support the different interventions that we operate to the different facilities. Thank you.
I think we need to answer close on business. Either sales are done or I'm done. I need to invite the team up front. Especially we're going to the last sessions where we had the ranking of our facilities based on performance. So I want to invite the team responsible to project our league table, and then we can use determine who did better than the other and give awards. But I see something projected. A few seconds as the league table is also projected. Very quickly.
Thank you, Gates. Mine is just a simple announcement that the Ministry of Health has changed from the annual client satisfaction surveys to a routine client satisfaction survey. On a daily basis, every client who comes to your facility should be able to give feedback through our system. There is an extra code that is supposed to be in your facilities. When clients come, please take them through the process. We discussed about it last time.
And if you can look at what I'm projecting there, the number of clients giving us feedback has increased, and therefore Ministry of Health is using that information to see how we can improve service delivery. All facilities within the district have created accounts for you, but the way, because these accounts seem to be confidential, I ask you, the in charges, to always send me an SMS asking your login details to that system. Everything is automated for you. You're not going to have to with analysis in that system. So there's a dashboard, you just click, select your facility. Now, since it's your facility, it will just pop up and you see the feedback. You are asking if you are able to engage with the communities to give us feedback. We have all the feedback, bitter and good feedback from the client, the right to themselves. Thank you so much. I was presenting. Thank you all of the juniors to tell us all the link table as of last financial year. Thank you.
Thank you. Ladies and gentlemen, my work is simple. Just need to take you through the overall performance, how our rank of facilities for last financial year. So we looked at certain different indicators that are critical for the national table, and we ranked our facilities. So we looked at the coverage of DPT3 for all facilities, and we're awarding points. We also looked at NC post coverage at facilities, and we awarded also points. We looked at pregnant mothers who have been tested for HIV for the first time, and also awarded points. We looked at also vitamin A second dose, deliveries units, IPT3 coverage. We saw that the previous presentation, we saw that IPT coverage is going on reducing, and yet this is one of the key indicators. We want to see prevention for mothers to get malaria when they are pregnant. So that is about IPT3. Then we looked at warming the last 6 months. This indicator looks at if we are doing the created child days in the month of April and October. Then also looked at deworming still for children under 5 years. So when we ranked all the facilities, we found out that the best facility among the health center 3 is Lima Health Center 3.
We need to keep inviting them up front. Let us have those people coming.
Okay, as they are coming.
Best performing.
Of course, the best performing. Then the second is Atandova. This is the Muslim facility around town here. Those are the best 2 facilities. Then it is followed by Isule, President and 3. So for the categories of state and risk, we picked out 4 health facilities. The best 3 Health risk and the best Health 2, and that is Kasese Health 2. The interview Kasese Health 2 is here. You can come and shake the hands of treatment and So the rest of the facilities, we have this one ready, and I'm going to share immediately on your WhatsApp and other platforms so that you can access the system. When we went to center 4 and hospitals, we also use the same parameters, but we will still look at other hospital and center 4 key indicators like maternal mortality, maternal and neonatal indicators. So when we look at that one, we can still bring it. But when we assess hospitals and center 4 on these indicators, we found out that the best hospital is the best hospital for last year is Mount St. Mary. Last year we got the best health center 4. But I think you understand me. The best hospital for this year is Mount St. Mary's. Then the Health Center 4 was Rukoki Health Center 4. That's what I'm trying to mean. So you can see today's appearance as a general hospital, but we are assessing the previous financial year. So people from Rukoki can come front, the team leader, the church. Then on St. Mary's, we have them here. On St. Mary's, you can also support them. So that's what I have for you about recognizing the best performing facilities, and these people will walk away with the certificates and their health raised. I think for me, that's the role of play now. Thank you.
Thank you so much. I know you mentioned that perform is better and well. We need to see them coming in front as we have some ceremonial where the leadership is going to award the certificates as a means of appreciation and creativity. To appreciate this come up front. I had the training session, I had the HIMA question, I had Kasese and Katado. Please come up front and then we do this ceremonial handover of certificates.
Thank you so much, Brother AHO. Using the powers given unto me, allow me to hand over these certificates. One is being awarded to Mount St. Mary's Hospital. Where is Mount St. Mary's? Congratulations and keep up with the spirit. We come to the second one, which is the Health Center 4. That is none other than Rukoki. Keep up with the spirit, we are greatly humbled. We come to a Health Center 3. Here, it is none other than the Isole Health Center 3. The in charge, Isole Health Center 3. He has multiplied himself by 0. Okay. The next one is Hima Health Center 3. Hima Health Center 3, the in charge. Any member from Hima Town Council? Yes. The other one is Katado, but this is Islamic. The one, this is for the Uganda Muslim Supreme Council Health Center. We have raised the humble. Keep up the spirit, congratulations. And lastly, we have Kasese Health Center 2. Thank you so much, and be bestowed on my territory for Kasese. This is for oh, thank you. Kasese Health Center 2. The only Health Center 2. The one for Isla is not yet available. Thank you so much, Bwana DHO. The representative of OBR, my Muzai, the senior citizen in Bombale, all the health in churches, and all people who are still present, I am greatly humbled. Ronald Gabriel is my name. I am the LC5 representative from Jarumata Mugaso, and I am here in the shoes of the chairman LC5, who has gone to attend his family political meeting in Kampala. All the same, I'm here to stand for him. I'm humbled with all the presentations which I come to you actually in. Together with me is the representative of the Secretary of Social Services, who is none other than Mahendo Edward. Remember, you can stand up for recognition. Is the district councillor representing the people of Jarumata County. I will not make a speech, but I'm just making a summary of, I call them announcements. Dear in-churches and all healthy workers, I kindly request you to always treat our clients just as you feel you must also be treated if you are the one. The language you use to these patients who are coming to your facilities will either make them come the following year or never ever come back to your facility based on the language you will have used all to them. In the same respect, I appreciate you for the kind of role you are doing in ensuring that the health services reach the people of Kasese, and we are grateful that in the previous financial year we have good promotions, especially in the area of health. We did not have Rukongi as a hospital, today it is. We did not have Nyabarongo as health center for, today we have it as health center for. We did not have Ugoi as health center for, today it is. There is one in the Munguyu, that is Kavingo Health Center too, that has been elevated to health center 3 centers. We are grateful and we thank you for all the efforts that you have surely put in that have made us reach that level. Thank you so much, and give up for the spirit. Serve the people as you are told to do, so that these services are felt in every community where they are. I'm also concerned with members. I pray that we still walk the talks which we are meant to do. The health in-charges. I'm overwhelmed. The health inspectors. I'm overwhelmed by the number of people who are advertising alcoholic drinks. I'm still worried. I don't know whether they are not going to cause any negative health impacts on our body. People are advertising alcoholic, everything alcoholic, day and night. I don't know whether they are passing through the reliable resources which you can rely on. Otherwise, it is causing panic in the minds of the community members. And lastly, neighbors, I also want to concern when somebody talking about commercializing some health services. I was in one of the hospitals in the month of April. Somebody was sick. Actually, was seriously sick, near the dying. This person needed to be transferred to Malaria. But when they jumped on the ambulance, the owners of the hospital demanded 900,000 as transport. This person told them, I have a brother who has a vehicle. Let us use that. They told him, we cannot transport a patient who is in this situation using your personal vehicle. Let us use an ambulance. This man told them, I have only 500. These people are not ready to release the patient. I got surprised. I don't know the approaches for the age of which you can use, especially to ensure that these ambulances become friendly, especially to our community. Otherwise, some are pretending the community not making it the relevance. Somebody says instead of telling you to board that ambulance, you better need to go and die from home. Let us try to come up with a mechanism of overcoming that particular problem. And in the same respect, members, you told me as a representative from the chairman LC5 to tell him on how to see a mechanism of not deepening his nose in the businesses of the district health officer. Yeah, that one I will deliver it verbatim. The way he told me, I will deliver it that way. Otherwise, it looks all that hard. When you are not a technocrat and you feel you will do the role of a technocrat, I pray that when we share with you, you will find a mechanism of